Now we will move into the fourth session, which is common problems in general practice. And I would like to introduce Dr. Anmar. He will be the moderator for this session.
Hi. Hi, everyone. Ani Anmar al-Witri. It's an honor to present for this session. I'd like to present our next speaker, Dr. Haidar Rida, a specialist for ENT. He provides specialist care for both children and adults, including surgical procedures and hearing services. He mainly diagnoses treatment of disorders related to ear, nose and throat, as well as head and neck surgery. Hey.
He's a neurosurgeon, and to my knowledge, he's the only Iraqi neurosurgeon.
There is another one in Brisbane.
In Brisbane, sorry, in Brisbane. Yes, yes. Thank you very much.
This is the So I'm going to talk about, thank you, about common ENT conditions. Thank you for the invite, Dr. Ahmed, and for the organizing committee. So it's going to be practical for you. First, what instruments you need? You actually need to have an alligator forceps. You need to have a headlight, and these days you can have headlights with loops. You can buy it like for $150 on Temu or on eBay. Quite good. It gives you good optics. Also, it's worthwhile seeing the mirror cell pack, which is the one in the middle below. You can buy it as, it's like a matchstick, small matchstick. You put it in the ear as a wick, and you get the drops to go on the top of it. It's going to soak the drops all the way inside the ear, and it can be quite helpful with otitis externa. After 2 days, most of the times it falls by itself when the swelling and the edema disappears. The name is Mirror Cell Pop Wicks, and the company that does it is called Medtronic. Normal tympanic membrane, so we start with the normal anatomy. Victor had a B pointer?
Yeah, the green one.
The green one, okay. Here. Okay, so this is the lateral process of the handle of the malleus. The most important landmark, actually, is the lateral process, not the cone of light. Always tilt the otoscope, look at the lateral process, then look above it to the pars flaccida. That's where you don't want to miss a cholesteatoma. This is the actual chorda tympani, and this is the longer process of the incus behind it, behind the handle of the malleus. So the lateral process is your most important landmark. Now, this is tympanoclerosis, normal white patches, tympanoclerosis, white patches on the tympanic membrane. It's a sign of degeneration, previous history of grommet insertion or ear infections, or both. It has no significance. It doesn't affect the hearing. It is just a sign of previous involvement of the tympanic membrane or the middle ear with something. This is exostosis, which we call surfer's ears, very common in coastal Australia. The problem with this is it does not cause hearing loss unless it's causing complete obstruction. It tends to accumulate the wax closer to the tympanic membrane, and the wax cannot migrate out. When somebody is swimming or having a shower, the water will go in and it will become smelly and rotten, and then it can lead to otitis externa. We tend to have quite high threshold for operating on this because the drilling of this can lead to high frequency hearing loss. So it is not as straightforward to remove it, and it takes ages to heal. It's very painful after the operation because you lose some of the skin and you have bare bone in the ear. So we tend to delay surgery. Now, this is a very important slide. We have on the left, cellulitis, where you see the ear lobule is involved. When in the middle, when it's only the cartilage, then that's perichondritis. The lobule is spared. You need to make that diagnosis because perichondritis is caused by Pseudomonas aeruginosa, and the cellulitis is caused by Staph aureus and Streptococcus. So you have to give the appropriate antibiotics. This is traumatic auricular hematoma. The next slide shows the problem here is the skin and the perichondrium are elevated from the cartilage, and you get a gap with loss of blood supply to a piece of the cartilage. So it's very important when you drain this or when you aspirate it as a general practitioner, and you can do that, it's not a big deal. Stick a needle and take it out, and then you have to put sutures. It's better to use nylon sutures all the way, like a quilting, transfixion sutures, and you put the knot in the back. So you go in, you go from out to in, then back to behind, and put the knot to drape the skin back and restore the blood supply. Insect in the ear, very common. I've seen mosquitoes, bees, lizards in the ear, you know, anything you see, especially in rural Australia. The most important thing here is the insect, usually it grips. It has a grip to the tympanic membrane, so you have to drown it first to release the grip, then you remove it. And then you cover with local antibiotic. Most of the times they would have caused perforation of the tympanic membrane. Usually it heals by itself. This is otitis externa. This is fungal otitis externa, usually caused by Candida or Aspergillus niger. The treatment here, always otitis externa, the treatment is topical. It's more effective. Antibiotics work, give you approximately 1,000 times the concentration in the external ear or in the middle ear compared to oral antibiotic. So 1,000 times more concentration. Therefore, if the ear canal is open like this and you have access to the treatment with ear drops, this is much more effective. So this is otitis externa, fungal otitis externa. Advise the patient to keep the ear waterproof. That's another one with a bit of eczematous otitis externa, so there's a blistering there. And this is diffuse otitis externa. Now, the problem with this is when you put the drops on, it's not going to get in. So that's when you need the pop wick that you can insert it in, or even a ribbon gauze, and then get the patient to put the drops on it. Then patient can pull it out himself in 2 days' time when the swelling disappears, and then he starts putting the drops directly into the ear when it is open. Otherwise, it's not going to get in. You can always give systemic antibiotic if there's constitutional symptoms or there's lymph nodes, or if you think it's quite severe and you can't get to the you can't get the drops in. Now, this is granulation tissue in the ear canal. It is an alarming sign. Granulation tissue is a sign of osteitis or periosteitis. It is a sign of either necrotizing otitis externa or it is a sign of cholesteatoma. Now, the difference, necrotizing otitis externa, is osteomyelitis of the temporal bone. I'll talk about it in the next slide. The treatment is quite long. It's a disease of immune-compromised people or diabetic. The cholesteatoma can happen with immune-competent and healthy people. So, when to suspect necrotizing otitis externa is when you have somebody who has the immune suppression, plus you see granulation tissue. It's caused usually by Pseudomonas aeruginosa or E. coli or Klebsiella. The treatment usually is systemic antibiotics. The way we investigate it usually with CT or MRI, and we usually ask for bone scan with gallium. The gallium scan is important for follow-up later. When the gallium signal stops showing, then it is okay to stop the antibiotic. Usually they need 2 to 3 months of treatment intravenously. So we put a Baxter pump for them and we give it intravenously. And sometimes we have to get them to have hyperbaric oxygen. And in Sydney, there's one place, which is the Prince of Wales Hospital, where you can have the hyperbaric treatment. When to refer ear diseases? When we have the non-resolving otitis, parotid or mastoid lymph nodes, and they are not responding to antibiotic. When you have cellulitis or perichondritis, and you think there is going to be or starting to have a collection. By the way, with the cellulitis or perichondritis, you can always give like Bactroban or something like Fusidine cream. 3 minutes? Temporomandibular joint involvement, and if there is a cranial nerve paralysis. I'll go to the next slide. This is black color tympanic membrane. It's either a trauma of the temporal bone or blood behind the tympanic membrane or high jugular bulb or epistaxis, goes through the eustachian tube. This is the acute otitis media. That's what it looks like. Sorry. That's what it looks like when you have an acute otitis media, bulging, angry-looking tympanic membrane. The other one is probably a beginning of otitis media. This needs antibiotic. The other one doesn't. You can cover the patient and with Nurofen and Panadol, and after 2 days, if there is no response, you can start the antibiotic. This is just a paper that talks about the need to wait before you give antibiotics and what are the criteria. If the patient generally, or if the kid doesn't look very agitated and doesn't look unwell, then you can continue with the medical, with the non-antibiotic treatment. Mastoiditis, I'll show you this slide. It's actually quite good. It's a slide. It shows the relationship of the mastoid to the middle ear. The mastoid cavity is very much like it is like the sinuses compared to the nasal cavity. This is the mastoid cavity, which is continuation of the middle ear. So remember, if there's middle ear infection, the infection can go to the mastoid, and it can work as a reservoir for future infections to come back after you treat the middle ear problem. Cholesteatoma. That's what I was talking about in the attic or in the posterior margin of the tympanic membrane. When you see what looks like wax above the lateral process of the malleus, be alarmed. When it is behind in the external auditory, behind in the tympanic membrane, in the back at the margin, then that could be a cholesteatoma. When you see white shadow behind the tympanic membrane, that could be a cholesteatoma. Now, this is CT scan of the temporal bone. There is opacification here in the middle ear cavity. This could be fluid or cholesteatoma. That's just the route of the spread of the cholesteatoma from the middle ear to the mastoid. The problem with cholesteatoma is it can lead to intracranial complications, and big part of the neurosurgical practice is from ENT, being ears or temporal bone or sinuses. This is the simple suppurative otitis media. You treat it with just simple antibiotic drops. You can give systemic antibiotic, but again, the same principle, 1,000 times concentration and water exposure. My suggestion always for eardrops, ciprofloxacin hydrocortisone or ciprofloxacin by itself. Ciprofloxacin hydrocortisone can sting the ears a bit. So for children, ciprofloxacin by itself. And for fungal infection, you use locacortin Vioform drops. Sofradex and Otocom, you can use it, but the problem is Otocom is very thick. It's like a glue. When you put it in the ear, frequently the patient will come back and tell you the ear is blocked. And this is middle ear fusion and about just putting grommets. One thing to take home is with adults with nasopharyngeal, with adults, middle ear fusion doesn't happen unless there is something in the postnasal space in about maybe 60 or 70% of people. So we always recommend examination of the postnasal space to exclude carcinoma, nasopharyngeal carcinoma. I think that's probably the most we can say. If you get a patient with sudden onset hearing loss, I would recommend starting them on steroid. They usually need MRI. Start on prednisolone, 50 milligrams per day for 10 days, then taper over another 5 days, while you're getting an audiogram and getting an ENT referral, giving the patient referral for ENT. But meanwhile, you have a window of 1 month to start treating the patient with a steroid before the patient will lose that window, and then there will be no improvement, and the ear is dead forever. Alarming symptoms in otology: non-resolving ear discharge, chronic temporal headache with discharge, and vertigo. If this is combined with vertigo, then that's quite serious. This is a sign of the intracranial spread of the middle ear, of the disease to the middle ear. Whenever you see granulation tissue inside the middle ear or cranial nerve paralysis, then that's alarming. I think epistaxis, you guys can manage it quite well. With a sinusitis, sometimes you can have orbital or intracranial complications. And when you see something like this is not a sebaceous cyst. This is actually called post-puffy tumor, and this is an osteomyelitis of the frontal bone. This can lead to superior sagittal sinus thrombosis or meningitis or intracranial abscess, so it is a very serious sign. Always send the patient for a CT scan, and you can see the opacification and the melting of the bone. It takes bone scan and gallium scan will make the diagnosis for you, of course, with the CT and the MRI. And this is just traumatic. 3 minutes? Okay, thank you. Thanks for that. Okay. Now, septal hematoma following an injury. It's exactly like the auricular hematoma. The septum has its only blood supply through the perichondrium. And when there is hematoma, the pericardium will be elevated from the cartilage, and you can get cartilage necrosis and then saddle nose or supratip depression, like this girl on the right. And therefore, it has to be drained, and the same thing, you have to redrape the mucosa back. With the nose, it's easier than the ear because you can put bilateral nasal packing to sandwich the mucosa back after you drain it. If you can't drain, just stick a needle and see after, after you put xylocaine in the nose, like xylocaine spray. But it has to be drained, and it has to be draped back. Normally, we put a drain like that one, Penrose drain. Cellulitis. And this is Bell's palsy. I'm sure you can manage it very well. And I just want to show you, this is post-tonsillectomy slough. This is actually not an infection. Frequently it's referred to as an infection. It is not an infection. This is a layer of dried saliva, fibrin, and white cells, and it takes about 10 days to disappear. And it can cause halitosis, it's painful at that time, and it sloughs and goes by itself. Eating normal food, like the food will rub on it and it'll come out. Chewing gum is very good. It'll exercise and move the muscles, prevents stiffness. Overall, after tonsillectomy, you advise the patient to eat and drink, and if they don't eat and drink, the risk of post-tonsillectomy bleed will go up. This is just a retropharyngeal abscess. Mainly those patients will have problem with neck stiffness and they cannot move their neck, and it is in extension position because of the spasm of the pre-spinal muscles and retrovertebral, prevertebral muscles. And anybody who has hoarseness for more than a month has to get an ENT referral to exclude carcinoma. And this is probably, I find, the easiest about stridor, the easiest classification. You have the paroxysmal type, which goes usually to pediatricians, laryngitis, epiglottitis, and croup, and the other ones are the apyroxyal ones, are usually congenital, except the foreign body. The take-home message here is if you have anybody that has sore throat with normal-looking tonsils or with previous tonsillectomy, think of epiglottitis because it progresses within hours. So quick referral to the emergency department if there are no tonsils and it's the pain is very bad with the drooling. Thank you very much. Sorry, it's a bit of rushed one. I had too many slides there.
Thank you. That was great. I have the honor of presenting my old friend, Dr. Ziad Al-Dabbagh, consultant dermatologist. He's highly experienced consultant dermatologist and a fellow of the Australasian College of Dermatology over the last, with over 18 years of clinical experience. I first met him in Jordan 20 years ago. He currently practices at St. Sinclair Dermatology in Melbourne, seeing patients at both the East Melbourne and Pascoe Vale South. His practice covers all aspects of general, surgical, cosmetic dermatology with particular focus on pediatric, hair and scalp disorder, inflammatory conditions, skin cancer management, laser and cosmetic dermatology, and autoimmune disorders. He's got a Bachelor Medicine and Surgery from University of Mosul, and then moved to Australia and completed his training. Thank you.
Thank you, everybody. Thank you for IAMA for inviting me to do this lecture. This is my second year here, and thank you for attending. So today, I'm going to actually go very fast, but feel free to stop me. There's a lot of slides, but always I like to, is the voice clear or there's a little bit of an echo? Clear? Okay, perfect. So I always like to start with a photo of Sir William Osler, he's not a dermatologist, but he's a Canadian physician, and he was one of the forefathers who established the Johns Hopkins University Modern Residency Training Program, and he's the guy who switched from where dermatology was mostly descriptive and giving lectures, and then he took the students and taught them to see the patient and look at the skin as a window into internal diseases. One of his famous says, see and then see again. Good eyes are the best physician's best tool, and we miss more by not seeing than not knowing, and we'll try to implement these today as we work through the slides. So mostly we have around 3,000, maybe roughly, well-known dermatological conditions, but basically you could actually classify them into these, put them in one of these 10 groups or categories. And you have, so you have papulous squamous disorder and eczema or non-papulous squamous disorders being the most common ones. As you know, obviously, papulous squamous, well-defined, psoriasis is the prime example. Eczema, you have that ill-defined borders. Eczema, actually, if you were in ancient Greece 500 years BC and used the word eczema, everybody would have understood you because it was mentioned and used first by Hippocrates, and it's mean boiling from the outside in ancient Greek. And that's basically what eczema, due to severe itching. We all know that with eczema, we have obviously the most common atopic dermatitis, which is the infantile stage where you have the cheeks, extensor surfaces, obviously that's very easy to diagnose, and then the flexural distribution mostly in the children moving to the teenager year. One of the questions you get asked frequently is, when will my child ever be cured? Obviously, we know that 70-80% of the kids will resolve when they're teenagers, but obviously 20-30% of the cases will go through the adult stage eczema, or they either have a mild generalized eczema, or they will have mostly what we have hands and periocular or orbital dermatitis. Eczema could be lichenified or subacute, like in this photo. They could have like the lichenification or the thickening, where you have the increased skin markings, and you have it acute. Tip is whenever you have an adult who presents you with just orbital ocular eczema, if they have history of eczema as a kid, yes, that's most likely common presentation. So the eczema resolves and they end up with just ocular eczema. If they don't have any history of atopic dermatitis, it's always worth to refer them for patch testing. And that applies also, the same thing applies to patients who have hand dermatitis. Obviously, contact dermatitis is a big one, but usually patch testing would be very helpful in those cases where you can't identify the trigger. I do get a lot of referrals with patients who have done all that radioallergist Serban technique, that LISA for, the dust and mites and everything, or they have already been sent to an allergist. This is usually testing for the, immediate hypersensitivity reaction, which you have your urticaria as a prime example, and not eczema, which is a Th2 or cell-mediated, where patch testing is helpful to rule out the allergic contact dermatitis. So there's no kind of specific text for eczema itself. This photo, obviously you would think eczema right away, but always when you see a little bit of atrophy in the skin and that wrinkling, especially in an adult, and where you have more on the buttock or covered areas, always think to rule out mycosis fungoides or cutaneous T-cell lymphoma by taking multiple 2 to 3 biopsies. And it's very actually overlapping with eczema. And there was a study that was done on average 7 years delayed diagnosis by dermatologists, thinking that this is a case of atopic dermatitis and end up being mycosis fungoides. So usually it's not very easy picked on, but always keep a left threshold to do multiple biopsies. Nowadays with eczema, obviously we have many new options. In Australia, currently we only have the Rinvoq and the Dupixent. This actually is a nice website from the Skin Health Institute in Victoria. It's called EasyDerm. You could always just put it in. If you're not sure if your patient roughly will be eligible for you just put the numbers in based on the erythema and duration, and it's very easy. It calculates within a minute, 10 seconds you can finish. And usually any score more than 20, your patients will be eligible for these, which will make significant difference. Obviously, these JAK inhibitors are targeted even Dupixent injections. There are many, obviously, in the drain coming soon, hopefully, if Donald Trump allows us to get these medications, because apparently he's not now allowing any medication to be sold cheaper than America. So another thing that I get, this rash in darker skin patients, always eczema in darker skin patients, most commonly, especially kids and teenagers, have a follicular pattern. So this is something that we see very commonly. It's not like in nitidus, it's not like in planus, it's eczema is very commonly seen in darker individuals, so papular or follicular dermatitis. Another thing, discoid, I mean, this is obviously contradicts what I said earlier when we said well-defined means psoriasis. It's one of the exceptions where you will have this well-defined plaques, round, circular. Sometimes they could be acute, or sometimes, which we call discoid eczema. Sometimes they could be subacute or even exudative. One of the things to differentiate them very easily from psoriasis, as you can see, usually the scales in psoriasis very well adherent, silvery, very difficult to remove them, right? While here, they're very fine, or pityriaciform, or more like mchala. They are very fine scales. So if you just get a little bit of a slide and you just scrape a little bit, then you will see this, what we call Osbit sign, pinpoint bleeding, due to the suprapapillary thinning and the dilated dermal papillae, which is very easy to diagnose if you're, obviously, sometimes we can't figure out by looking ourselves. Pumphelix, a variant of eczema, deep-seated papular lesions of sign of fingers, very itchy. A thing here is always to check. Pumphelix is a very common id reaction, so it's a reaction to an underlying infection, whether it's always look between the toes. Tinea pedis is very commonly associated, onychomycosis, any other skin infection, and patients are very surprised. I tell them, do you have like a little bit of tinea there? Oh, how did you know? It's very commonly associated with Pumphelix. Treat the tinea, Pumphelix will go by itself. So Pumphelix, this hydrotic eczema, bullous, Pumphelix. I just wanted to speak a couple of words about dermatosis of pregnancy, because obviously we're always alarmed. We don't know, especially with pregnant ladies, we're very, trying to not prescribe or medications as much as we can. So usually with a dermatosis of pregnancy, 90% of your patients will have one of these 4 conditions. So when you see this condition starts usually mostly over the abdominal area, and it's accentuated over the stria. So you see these articulated lesions over the stria, then spread a little bit. It really respects the umbilicus area, so it doesn't involve the umbilicus area, and this is what we call polymorphic eruption of pregnancy. The theory is it happens usually in a primary patient, usually in the late stage of pregnancy. Why in a primary? Because you have the sudden stretch that happened in the abdomen, and you have the damage to the connective tissue, the collagen, and this creates a kind of, the theory is a cell-mediated immune reaction that causes this reaction. It doesn't affect the baby. It's very common, resolved within 4 weeks. You reassure the mother, a little bit of topicals, good old steroids will do the trick, or antihistamines. Another one that you see that actually, sorry, this is the same thing. So this is actually a better photo where you see the accentuation. It's called polymorphic eruption because you may have it at dermatitis, but most likely it's urticarial, let's say. This one where you may have blisters. When you see a blister in a pregnant lady, always make sure to biopsy because you want to rule out pemphigo gestationis. And this actually does not respect the umbilicus at all, the umbilicus region. It involves it, not like, that's one of the hints. And it's also mostly concentrated on the abdominal area. This actually could cause preterm delivery. It could cause small for age babies. So always it's very important to promptly diagnose it. Another very important one where you don't see a primary skin lesion. So basically intense itching, most likely starting like in the 3rd trimester. And you see a little bit of excoriation. So you think scabies, first of all, because there's nothing to see, just excoriation or prurigo lesion. Think always about intrahepatic cholestasis of pregnancy. It's not an uncommon one, and always doing a liver function test and a bile acid test, where always you will see that is elevated, and I always do liver function test with any pregnant lady anyway with a bile acid test. And obviously it's due to the toxic bile acid and kind of crossing the placenta, and this could have actually severe consequences for the baby, fetal distress, and stillbirths. So this is actually the most important one you have to pick up. It's very easy to treat with a little bit of R-deoxycholic acid, which is a natural hydrophilic bile acid, which will treat the area. Obviously, always use our GI friends. We have many actually in our IAMA we could always consult. Another one that starts mostly much earlier, this is the most common, maybe 1 in every 5 or 20 pregnancy could happen, which is atopic eruption of pregnancy. 20% of them have pre-existing eczema, but 80% is just predisposed during the pregnancy, like the adult onset atopic dermatitis, because now we have adult onset and we have late onset atopic dermatitis. Before, we used to think of it more of a newborn baby disease of kids. I am counting with you. Also, whenever you see urticarial lesions, like in here, with eczema lesions, there's nothing, as we were saying, like a type 1 and a type 4 together. Doesn't make sense. The only thing that could cause that, always think about scabies when you see both of these clinical pictures. And obviously, with scabies, checking for the boros, where that's the only, maybe somebody who's infected with scabies will have 7-8 mites, an immunocompetent adult. And it's very difficult to find these mites in the boros, linear tortuous lines, as you all know. So usually it's a clinical diagnosis. A very useful hint is these rubbery nodules in the genital area, the axilla around the nipples in the ladies, where it's usually the antigen itself of the scabies where there has been formed acidolymphoma. Obviously, I'm starting, I don't know about you guys, but half of my patients who I prescribe permethrin are coming back with failure of treatment. There's apparently more of a resistance thing going in Australia, so I'm starting with ivermectin anyways, even with kids. Prurigo nodularis is another form of eczema. It's basically a lichen simplex, generalized lichen simplex chronicus. Iron studies is very important, iron deficiency anemia, and also do a kidney function test. That's also, usually you see the butterfly sign because they're mostly induced by the patient and they can't reach that same sign you see in scabies too. We're still waiting the interleukin 31, hopefully soon, which will make a big difference in those patients. It's approved by TGA. Seborrheic dermatitis, cradle cap, obviously we all know that. Nasolabial fold involvement, retroauricular involvement, scalp involvement. Rosacea, on the other hand, very obviously, with rosacea, it's always important to know which stage of rosacea you're treating. You look at it as a more 3D dimensional, because erythematotelangiectatic, where you have the flushing and the fixed erythema later on, the only thing that will help with these patients is a little bit of vascular laser, or even you could give them actually this, Mirvaso. It's not covered by PBS, but it's an alpha-2 agonist that actually temporarily provides vasoconstriction. Many patients are happy just using, this when they have a certain occasion. Just one more minute. And also, when you have inflammatory component, you have your azelaic acids, your metronidazole. Also, I don't see a lot of GPs prescribing ivermectin, which is less irritative and also have better results in many studies compared to metronidazole and azelaic acid. Obviously, tetracyclines, and then you have the isotretinoin, which is helpful. Not a lot of things that could cause cobblestoning of the nose. The only thing in dermatology that could cause that cobblestoning is rosacea. Also, always remember to ask about ocular involvement, which is around 15%. And finally, obviously, comedones will differentiate between acne and rosacea. That's the most common thing to look for and to know how to manage. There's a couple of others, actually much more slides, but hopefully at another occasion we'll be able to do another lecture. Thank you very much.
Thank you, Dr. Ziad. Okay. Our next speaker is Associate Professor Batul Nadam. Dr. Nadam is a consultant obstetrician, gynecologist with extensive experience in all aspects of women's health. fellow of the Royal Australasian College of Australia and New Zealand College of Obstetricians and Gynecology. Additionally, she has completed 2-year fellowship, advanced laparoscopic gynecological surgery, obtained subspecialty in obstetrics and gynecology, ultrasound from the Australasian Society of Ultrasound and Medicine in 2018, and a member of the International Society of Ultrasound Obstetrics and Gynecology. Has a PhD from the University of Sydney and an academic lecturer at the University of Notre Dame. Batul has extensive knowledge, experience, and specialist skills in managing a range of issues related to women's health, including pregnancy, childbirth, and has special interest in chronic pelvic pain, endometriosis, and tertiary level scans. Currently working as a visiting medical officer at Hawkesbury Hospital and Nepean Hospital, where I sort of cross paths with her, and Norwest Private Hospital. She's committed to excellence in healthcare and passionate advocate for women's health. She values women's knowledge and skills and their right to make informed decisions about their health concerns and their management. Thank you.
Thank you, everybody. Thank you very much for the organizing committee to invite me to talk today in this meeting. I have the pleasure to meet all of you and meet my colleagues, friends, and meet new people from all parts of Australia. Now, I know it's afternoon and I know everybody is really feeling tired, so I'll cruise through very quickly. Now, my topic is polycystic ovarian syndrome. This lecture will encompass whatever we've been talking about since morning. We're going to touch on all aspects of medicine in this one. I'll be very quick and just emphasize the important parts. So polycystic ovary syndrome is very common. It affects 8 to 13% of reproductive age group women. But unfortunately, around 70% of these women are underdiagnosed. The reason for that, because it presents differently in different ethnic groups, and also it presents differently in high-risk groups, especially indigenous women, where the prevalence and the complication is higher. All these lovely ladies have polycystic ovary, and you know each one of them is presenting in a different way. Now, as I said, this lecture encompasses all what we've been hearing since morning. So how are we going to navigate this lecture? We're going to talk about the feature, how to diagnose, why it is important to diagnose it, what are the steps to diagnose it, how do we screen for it, and the management. I'll touch very quickly on it. Now, as you are aware, polycystic ovary syndrome, it comes, like the origin of it encompasses multiple origins, where there is genetic factors, neuroendocrine, metabolic, environment, and steroidogenesis. We'll not elaborate on that. I just wanted you to realize that there is no one reason, there is multiple causes. Usually, polycystic ovary present with features. The reproductive one, obviously, the irregular cycles, hirsutism, infertility, and pregnancy complication. Metabolic presents as insulin resistance, type 2 diabetes, and cardiovascular risk factors. And less looked at is the psychological anxiety, depression, and body image. Why it is important to look at polycystic ovary syndrome? Polycystic ovary syndrome is not only gynecological or obstetric problem. It imposes major health implication to the women's health. One of it is the obesity, and we had an excellent session on obesity today morning. So in polycystic women, the prevalence of obesity is higher than general population. The rate of weight gain also is higher in polycystic ovary syndrome population. And also it has a genetic predilection. And also when we look at in general population, the temporal increase in obesity is much manifest higher in the polycystic population. The rate of weight gain in polycystic women is higher, where we can see that when they did a population study, looking longitudinally on the rate of weight gain in women, the women with polycystic ovary, they have 2.6 kg higher rate of weight gain than the general population. Most importantly, that the weight gain starts early from adolescence. And this is where comes our impact, is we need to diagnose properly so we prevent that from this young age group. The most important indicator of the weight increase is the progressive increase in waist to hip ratio. In women, in general, there is two timelines where we look at that, is between 20 and 25 years old and 40 and 45 years old. The psychosocial impact, which is less acknowledged by us clinicians, most of these ladies, they have negative body image and weight stigma, almost a third of them. They present with eating disorder, and they have psychosexual dysfunction. The rate of diabetes in polycystic women is also high, and then from this slide you can see that there is almost 2 to 3 times increased risk factor in diabetes and insulin resistance and in impaired glucose tolerance. Risk of obstructive sleep apnea also is higher in ladies with polycystic ovaries. We could see that it is 10 times higher in polycystic women, and also in subgroup of women where the BMI is high, then even the mild sleep apnea is 7 times higher. Cardiovascular risk factor is also high, where there is 1.68 odd ratio. And not only that, but recent study has showed that male relatives of the female with polycystic ovary also have higher risk factor for cardiovascular diseases. So in the fathers, there is 2.3-fold increase, and in the brothers, there's 3.9 increase. And that emphasizes the importance of screening. Unfortunately, there isn't adequate data to look at the women, so you males, be careful. Endometrial hyperplasia is really a risk factor because it imposes the woman to risk of endometrial cancer. So there is an odd ratio of 6.01 increased risk of endometrial hyperplasia and endometrial cancer. Now, everything I'm going to talk about is coming from this guidelines, which is an international evidence-based guideline, and we follow that for screening and diagnosis and management of those women. How do we diagnose polycystic ovary? The typical polycystic ovary, which was prescribed earlier in 1935 by Steen Leventhal, was infertility, amenorrhea, and enlarged ovaries. And this started from long back ago, from 1721, where that was the first ever described polycystic ovary in an infertile married woman with big ovaries. Now, the criteria to diagnose polycystic ovary has changed over the years, and what we follow now is the Rotterdam criteria from 2003. Basically, we need 2 out of the 3. Ovulatory dysfunction, hyperandrogenism, whether it's clinical or biochemical, and the polycystic ovary morphology with exclusion of thyroid disease and hyperprolactinemia and the adrenal hyperplasia. Now, I wouldn't talk much about this slide, but this is just tells you the difference between when we first started to diagnose and the one. Before, we needed all of them. Now we need 2 out of 3. So a woman may come with ovulatory dysfunction, hirsutism, but normal ovaries. A woman will come with ovaries, ovulatory dysfunction, but no androgenism. Or come with hirsutism, hyperandrogenemia with polycystic ovary, but normal ovaries and ovulation. Normal cycle ovulation. What we need to be aware of also is the ethnic variation in the presentation. It presents differently in different ethnic groups. So we need to be aware that severe hirsutism is common in Middle Eastern, Hispanic, and Mediterranean people. Also, central adiposity is more common in Southeast Asian, indigenous Australian. East Asian have lower BMI compared to their peer group, and also higher BMI is also more prevalent in Africans. So the way we look at it differently in different people. Let's define what is ovulatory dysfunction and irregular cycle. The guidelines tell us we should not label a woman having irregular cycle unless it is 1 to 3 years post-menarche, if that period is less than 21 days or more than 45 days. If the woman is 3 years post-menarche to the area of perimenopause, then look at the number, it's 35 days, not the 45. Or if she presents with less than 8 cycles per year in this age group, if the woman has come 1 year post-menarche where she has a cycle 90 days apart, only one cycle, or if she has primary amenorrhea by the age of 15 or 3 years post-terlaki, that's where is the breast developed. Now we'll have to be careful in the group of adolescents. You cannot imagine how much psychological impact you put on a girl, 15, 16 years old, and you tell her you have polycystic ovary, and she grow up with this one. Like, it really destroys their life. When they reach their 20s, they are really distorted body image, they can't have relationships, and they withdrawn from the society. So we need to be careful in this age group. In this age group, how we diagnose polycystic ovary, with the symptoms, irregular cycles, we'll have to be careful. We'll have to wait till 8 years post the puberty. During this time period, we keep on monitoring, During this period, we keep on monitoring. We just don't say, no, you don't have it, go. We keep on bringing them back for monitoring, asking about symptoms, and I'll show you the frequency of monitoring later on. But we keep on looking after them till they finish the 8 years, and then we are certain of the diagnosis. Please don't label them polycystic till then. I have seen people 11 years old and they tell them you are polycystic ovaries. Now, depending on the regularity of the cycle is not a definite thing, because we still could be anovulatory with regular cycle. If you are in doubt, if you see that this girl had other symptoms and you want to test for being anovulatory, do serum progesterone. Now, what do we mean by clinical hyperandrogenism? We said hyperandrogenism could be diagnosed by symptoms or clinical or by biochemical test. So what do we mean by clinical? Clinical is really hirsutism and acne. And even with that, we need to be careful. We need to have a scale to measure what do we mean by hirsutism and acne. And you spoke about obstetrics in your lecture, Dr. Ziad. I'm going to speak about dermatology in my lecture. So hirsutism is defined by increased hair, and we use the modified Fuhrman-Galloway scores to indicate how bad is hirsutism, and usually levels above 4 to 6. And this is how does it look like. So it divides the body into areas, and we look at the hair in these areas. Alopecia is another part of hyperandrogenism, and we use the Lidwig alopecia scale. Acne, there is no scale to measure acne, but if anybody comes complaining of bothering acne, then that is significant. Biochemical assessment, as we are aware, is measuring the blood, and we should be careful with the reference because each lab has its own reference. And if the levels are so much higher, then we look for neoplasia. We measure free testosterone, free androgen index, and calculated bioavailable testosterone. Be careful with the DHEAS because it's not specific. And we cannot measure these hormones if the woman taking contraceptive pill. She should stop it at least 3 months before measuring it. Now, does polycystic ovary happen in menopause? Yes, it does. It's not having menopause. You don't have polycystic ovary. It's just been masked or missed. And those people who go to menopause with polycystic ovary, they go to menopause later and they have more hirsutism. The anti-millennial hormone is a new trend. Now everybody is doing it, and we know that it's high in polycystic women, but it should not be used as a diagnosis for polycystic ovary. It does change with age, and if the woman was taking hormone contraception or she had a surgery on her ovary, and it does vary with the body mass index too. Now the ultrasound, this is important because the ultrasound definition of polycystic ovary has changed. Nowadays we have a newer ultrasound machine, very high resolution. We can count the follicles. And counting the follicles, it should be more than 20 follicles or ovarian volume of 10 ml. Older machines, they cannot measure the follicles, so we depend on the volume, 10 ml. And counting the follicle is in all around the machine. If it is only in one side in 2D, it should be more than 10 follicle per session or per, what do you call it? Yeah, per sorry. So that's how the polycystic ovary look like. This is the newer machine where you can see it is calculated all of these follicles in one go. Screening, as I said, that polycystic ovary is coming with so much impact on the woman's life. So we should not only diagnose and that's it, we should bring her frequently for screening. One of the things which is missed is the quality of life. These women really are impacted psychologically, so they are withdrawn, they don't go out, they are worried about their body, and they don't have relationships. So we should screen them for quality of life with this. This is proposed by the guideline, which they call the PCOS quality of life tool, which is questionnaires. We should also scan them for anxiety and depressive symptoms, psychosexual problem, and eating disorder, which is not usually a common practice, but they do come with eating disorder, so please screen for that. Weight assessment, it should be in a minimum every 6 to 12 months. We do the waist-hip ratio. For endometrial cancer, there is no guidelines when to screen for it, but if the woman is symptomatic with bleeding, then we'll have to do minimum ultrasound and endometrial biopsy. But just to screen, like we bring her every year for ultrasound, is not indicated. Cardiovascular risk depends on the woman, her body mass index, and if she has hypercholesteremia, then the frequency of doing screening for cardiovascular risk depends on the risk factor, but every woman should have a baseline cholesterol and lipids, and measuring blood pressure annually. For diabetes, it's advisable to do it every 1 to 3 years with a formal oral glucose test. In pregnancy, as you are aware, we should do oral glucose test prior to pregnancy, and if a pregnancy, before 20 weeks. Now, I know my time is finished, so I'm going to stop here. But if you want to ask me about treatment and everything, we'll do it later on. Thank you very much.
Thank you, Dr. Batul. But I'd like to invite the last, well, Dr. Batul and the other two speakers to come for a little Q&A. Any questions? Yeah.
Excellent presentations, all of them. Dr. Batul, my question for polycystic ovaries and ultrasound. When it's typical appearance, everybody's happy. But we find quite a few gray areas where it's atypical sonography appearance. So you have the multifollicles, you have a size of ovary which is more than 10 cc, but you have a dominant follicle in one of the ovaries. We say 20 cysts, less than 10 millimeter each. But here it is one like 20 or 15 millimeter. With that discarded, I mean, I sometimes when it's atypical, ultrasound presentation ask for hormonal assessment as well. Do you think that's fair or follow-up, or what's your advice?
Well, the guidelines are very clear. Whenever you have an ovary which is 10 mil and above, is polycystic. So we name it polycystic. When you have a dominant follicle, which is, let's say, more than 9 millimeter, count the other follicles. So if you discard this one and you have more than 20, then that's still polycystic. The other thing is, if only you have polycystic ovary, only on the ultrasound, and the woman is asymptomatic, she doesn't fall into the category of defining polycystic ovary syndrome. This woman needs more workup, which is taking proper history, doing blood tests and all this stuff. If we got 2 out of the 3 criteria, then she does have it. Polycystic ovary on ultrasound, we don't need both of the ovaries to look polycystic. If one of them is polycystic, then that's it. It confirms the diagnosis.
And what's the best time during the period? I mean, which day to send the patient for ultrasound?
There is no day. You can send her to ultrasound any day.
Any day.
Polycystic ovary does not change with the date of the cycle. What changes is the endometrial thickness. Early in the cycle, endometrial thickness is thin, and it goes with the date, like date 1, 1, 2, 3, 4. Reaches mid of the cycle, it reaches 10 to 12, and afterwards stay around that till we have the menstrual cycle.
Dr. Haida, this is Sabah Al-Mullah. In regard to quinsy, a quick review or speech about management of quinsy, that's number one. And what about tinnitus? What do you, at GP and at surgeon level?
The peritonsillar abscess or the quinsy, first thing you should have trismus. That's your most important consistent sign, always. If you actually think that there's a quinsy, the patient has a quinsy without trismus, then revise the diagnosis. It has to be with tonsillitis, of course. So tonsillitis, sore throat, followed by trismus, and ability to open the mouth with neck pain or neck swelling. But the trismus is the most consistent one. Always treatment involves drainage if there is confirmation. You can drain it as, like in the hospital, we drain it with lancing it, or you can just stick a needle and get it aspirated. If you can't drain it, covering with benzyl penicillin with metronidazole. Always you need to cover anaerobic infection because large number of them, they have bacteroids. The problem with peritonsillar abscess is if it doesn't get treated, it can become a parapharyngeal or neck space infection. And we see that quite often. Mostly we do when somebody comes with peritonsillar abscess and there is no improvement within like a couple of days of IV antibiotics and drainage, we proceed for quinsy tonsillectomy in the same admission. That reduces the morbidity and further need for readmission for a tonsillectomy. It's one week pain as part of the peritonsillar abscess and things improve. Regarding the tinnitus, tinnitus is very important. If the tinnitus is the nature of it, if it is pulsatile, then you want to make sure it's not a vascular problem. So you want to exclude carotid artery narrowing. So it's a standard. We do Doppler ultrasound for them. We do MRI brain and MR angiogram of the brain to exclude aneurysms, carotid artery narrowing, or any aberrant vessel in the brain or in around the ear, in the skull base. If it is a high-pitched noise or tone, like being tone or buzzing or ringing, then it's mostly related to hearing loss. So you have a high-frequency loss, or you usually have hearing loss around the same frequency of the tinnitus. If you feel a high-pitched noise, or if the patient hears high-pitched noise, then usually the dip on the audiogram is around that particular tones, and we can match it. Now, audiogram is important, MRI is important, because tinnitus, about 70% of them, it's idiopathic, 30% could be related to cerebellopontine angle neoplasm, like acoustic neuroma. So, MRI. Treatment-wise, so we said MRI scan, or managing, looking for a vascular cause if it is pulsating tinnitus. Then the treatment would be, if it is a tone and the patient has significant hearing loss, the hearing aid will be the solution. That will suppress and distract the patient from the tinnitus. Second thing, now on the smartphone, there are applications called tinnitus masker, where you can match, I can show it to you after the talk, it's an application, you can match what the patient hears, provided that you excluded acoustic neuroma with an MRI scan. You can match what the patient hears. They can put a headphone and read a book for half an hour before they go to bed. And with the matching noise applied into the ear with a headphone, it will suppress the tinnitus. Third way to treat the tinnitus is if you have somebody who's really disturbed, actually amitriptyline. We start with 10 milligrams, especially if it is at night, bedtime. It can work. And you need to warn the patient that it may take a month to 6 weeks before you actually see the response. So tell him not to stop the medication unless you use it for that period of time. Amitriptyline, you can go up with the dose up to 25 milligrams 3 times a day. Okay, thank you.
One last question.
Sorry, Dr. Batul, regarding the blood test for the PCOS, is there any time specific during the cycle?
No, we prefer it in the first week after the cycle. That's what we prefer.
First week after the
Yes,
cycle.
but if you can't fit it in, it should be all right.
All right, thank you.
I'd like to thank the speakers. Thank you so much.